Good afternoon, dear colleagues and participants. Welcome to the ESG webinar, Oncology in Adolescence, its consequences and after effects. Today's webinar is about to start. My name is Ineta Vasaraudze, President of Latvian Society of Gynecological Endocrinology and board member of the ESG. I'm honored to moderate today's session. Before we start, an important note regarding our today's agenda. Due to unavoidable prior commitments, our first speaker, Professor Zana Bumbulienė, will have to leave the webinar shortly after the talk. Therefore, we will hold a dedicated Q&A session for her immediately after her presentation. I kindly ask you to submit your questions in the Q&A box while she is speaking, so we can address them before she departs. Now, it is my privilege to introduce our first speaker, Professor Zana Bumbulienė. She is a professor of Vilnius University, a leading expert in pediatric and adolescent gynecology in Lithuania, and a board member of several international scientific societies, including ESG, ESGE, and Europac. Today she will present reproductive outcomes in survivors of childhood cancers. Professor, the virtual floor is yours.
Thank you for your kind introduction, and I would like to speak today about reproductive outcomes in survivors of childhood cancer. And I will start from the most common types of cancer among children. Then I will go to late effects. We will speak about premature ovarian insufficiency, counseling possibilities, and I will sum up my talk in several key points. As we know, cancer is the second most common cause of death in children aged less than 15 years in developed countries. And the most common types of cancer among children less than 16-year-old are leukemia, brain and other CNS tumors, lymphomas, neuroblastoma, kidney tumors, and malignant bone tumors. Among adolescents aged 15-19, brain and other CNS tumors, lymphomas, leukemia, thyroid cancer, but also ovarian germ cell tumors and malignant bone tumors are the most common cancers. Risk factors of childhood cancer. First of all, genetic factors, inherited mutation in tumor suppressor genes or oncogenes in some congenital syndromes. Very important are prenatal and perinatal factors. Parental exposure to chemicals, radiation, or chemotherapy before conception, but also maternal smoking, alcohol, and certain medication use. Infection agents, some of viruses are linked to specific cancer. For example, Epstein-Barr virus is responsible for Burkitt lymphoma. And environmental factors, ionizing radiation, chemicals, they can be as triggers to develop cancer. As I mentioned, genetic, prenatal and perinatal factors, infection agents, and environmental exposures. Childhood cancers, as I mentioned, are curable, and we can use one or a combination of 3 treatments: chemotherapy, including biological immunotherapy, radiation therapy, and surgery. Aggressive cancers might require intensive multimodal therapies, and in our day survival rates and the five-year survival rates now exceed more than 80% in developed countries. And it is estimated that in Europe alone live between 300,000 to 500,000 survivors. And each year, 12,000 more survivors add to these pools. And the estimated number of survivors of childhood cancer in the general population in Europe is 1 in 1,000. But survivors of childhood cancer, it means pediatric population have their whole life ahead of them. That's why diagnosis, treatment, and prevention of late complication are critical. And cancer disease itself, and as well as life-saving treatment, may carry with it a risk of immediate or late adverse effects. And late effects manifest numerous clinical conditions, and here you see some of them: growth, puberty, endocrine, reproductive dysfunctions, and other. For us, as for gynecologists, the most important are reproductive late effects, including problems of puberty, precocious or delayed puberty, altered menarche, infertility, diminished ovarian reserve, and premature ovarian insufficiency. These adverse reproductive outcomes also extend to pregnancy outcomes, including preterm birth, low birth weight, and miscarriage. I would like to remind you very well-known curve, the size of follicle pool during the female life. And I would like to highlight that human ovary is active during childhood as well, and follicles are recruited for maturation at all ages, differentiate into preantral and antral follicles, but in the absence of sufficient gonadotropic support during prepubertal ages, undergo atresia before reaching preovulatory sizes. In young women with premature ovarian insufficiency after radiation or chemotherapy, the depletion of ovarian follicle pools occur substantially early. And here you see, for example, as red line. And it is, or blue line is the natural menopausal transition. As follicular depletion progresses, the number of granulosa cells decreases, and it results in reduced anti-Müllerian hormone and inhibin concentration. And consequently, negative feedback on hypothalamus ovary, pituitary ovary axis leads to elevated FSH levels and hypoestrogenism, and in premature ovarian insufficiency, we can see the amenorrhea together with hypoestrogenism. And here you can see the spectrum of premature ovarian insufficiency. Sometimes we had acute onset, the ovarian insufficiency. It is during or immediately after therapy. It starts from amenorrhea. In this case, we have high FSH and low anti-Müllerian hormone level. It is reasonably predictable because the measured risk factors are high dose chemotherapy, especially with alkylating agents, and also bone marrow transplantation. Late onset premature ovarian insufficiency, or we can speak also about premature menopause, is after 5 years from the time of diagnosis, but before the age of 40, it is difficult to predict how long we will have the normal menstruation, because the risk factors can be any chemotherapy, radiotherapy, or hematopoietic stem cells transplantation. So now I am going to outline the negative effects of most common oncological therapies, such as radiotherapy and chemotherapy. So the impact of radiotherapy on endocrine and reproductive function is dependent on the age of child, the total dose of irradiation, and the location. So if location is hypothalamic pituitary irradiation, and we have dose approximately 18 gray, it is associated with the risk of central precocious puberty in girls. But if the doses are more than 30 or 40, it can lead to hypogonadotropic hypogonadism, delayed puberty, menstrual dysfunction, and infertility. Then we have pelvic or abdomen irradiation. Even low doses, around 2 gray, may damage 50% of immature oocytes. Doses 4 to 6 gray increase risk of impaired fertility, and doses more than 20 gray generally result in irreversible ovarian insufficiency. What about uterine damage? So if we have the uterine exposure to 14-20 gray during childhood, it impairs uterine growth and vascularization, and consequences include reduced uterine volume, endometrial damage, and decreased uterine elasticity. And these changes are associated with increased risk of miscarriage, preterm birth, placental abnormalities, and low birth weight. What about chemotherapy? First of all, mechanism of action, that chemotherapy damages the DNA in all sites. It also disrupts mitochondrial integrity. Some drugs trigger premature follicular activation, pushing them into developmental pathways they cannot complete, and hastering depletion of the ovarian reserve, and also disrupt oocyte meiosis. And it is important to understand that chemotherapy influences not only hormone production, but also is responsible for fertility. In some cases, we can have even sterilization. And the degree of ovarian toxicity is highly dependent on age and treatment, as younger women generally have a larger ovarian reserve, making them somewhat more resilient. The next, chemotherapy regimen and dosage. As I mentioned, alkylating agents are the most gonadotoxic, but in bone marrow transplantation, we use not only highest doses of chemotherapy, but also gonadotoxic chemotherapy with total body irradiation, and it was the highest risk for premature ovarian insufficiency. And that's why we have clinical consequences, premature ovarian insufficiency. It can be altered menstrual cycles and reduced fertility potential. And it depends what kind of chemotherapy we use. In some cases, we have very low risk of ovarian failure. In others, very high risk. And pubertal disorders, as I mentioned, treatment dependent, and if we have cranial irradiation in leukemia or in brain tumors, in most cases we will have precocious puberty. But if it is bone marrow transplantation with total body irradiation or chemotherapy, we will have delayed puberty and amenorrhea as well in brain tumors with cranial irradiation. So how to measure reproductive function of our childhood cancer survivors? So no perfect index of ovarian reserve exists, and multiple measures are usually combined. First of all, the menstrual history, the ultrasound evaluation of ovaries, but also hormonal markers. But for example, FSH is not so informative in children. We can use only after 13 years of age. Inhibin B, till now, the predictive value for fertility is unclear. So promising marker of ovarian reserve is anti-Mullerian hormone. And we know that post-chemotherapy levels of anti-Mullerian hormone are significantly lower than in control groups. But also in hematological malignancies, we have low pretreatment anti-Mullerian hormone. And we know that low hormone does not necessarily indicate reduced fertility in healthy women. That's why we can use this anti-Mullerian hormone as a marker of ovarian reserve in cancer patients, not as predictor of fertility. So how to protect fertility? As in hematological malignancies, prompt treatment is critical in childhood cancers. So immediate chemotherapy is often required, leaving little or no time for pretreatment ovarian tissue collection. That's why, as a result, the ovarian tissue cryopreservation may need to be performed after chemotherapy, and fertility preservation strategies must be planned rapidly, or often in parallel with urgent cancer therapy. That's why it's very important early consultation with oncofertility specialists. During radiotherapy, protective strategies are ovarian shielding, it's just physical protection from radiotherapy, ovarian transposition, it is surgical repositioning of the ovaries out of the radiation field. We can, if it is possible, lower radiation doses and smaller treatment volume used, and also we can use oocyte ovarian tissue cryopreservation before radiotherapy. But even with protection, some ovarian damage is often unavoidable. What about the protective strategies during chemotherapy? We can use gonadotropin-releasing hormone agonists who suppress ovarian function, but they are not fully protective for highly gonadotoxic regimens. We can use cryopreservation. Preclinical studies show some antioxidants can reduce follicle apoptosis, and now promising in animal studies is research exploring mesenchymal stem cells or ovarian stem cells transplantation. But it is only early phase human trials. So there are fertility preservation options available for prepubertal and postpubertal girls. And right now, the only viable solution for prepubertal girls is ovarian tissue cryopreservation. If the girl is postpubertal and her cancer therapy can be postponed for 1 or 2 weeks, ovarian hyperstimulation and cryopreservation of oocyte might be considered. And if we speak about ovarian tissue cryopreservation, we know that till now it is experimental, but many centers used it because it is applicable to prepubertal girls, does not require ovarian stimulation, preserves a large number of primordial follicles, and it is potential restoration of endocrine and fertility function. But its disadvantages are because it requires surgical procedure, still experimental, risk of reintroducing malignant cells, especially in hematological cancers, and follicles may be lost during freezing, storage, and require specialized centers. So, in these girls, very important is counseling, and parents and physicians play crucial roles in shaping the reproductive future of pediatric cancer patients. And it is essential to select patients eligible for ovarian cryopreservation. But very often we cannot produce treatment response, and the risk assessment can be different at the beginning and later. So risk of infertility after cancer treatment should be discussed prior to the initiation of cancer therapy. And families should be informed about the available fertility preservation option in this center or this clinic. Girls and their families should be consulted regarding the possibility of abnormal pubertal progression, about menstrual dysfunction, and if they have still a window of opportunity for fertility, they should be advised not to delay their childbearing. And when we can speak about reimplantation of ovarian tissue, So it is only in patients which are in remission, then there is minimal risk of malignant contamination. The girl is in disease-free interval, and very important is the type of primary malignancy. We can restore endocrine function and also fertility. And there are successful cases in literature. But sometimes the girls have no opportunity to protect their fertility, and we have premature ovarian insufficiency even in small girls. So then we treat according to the guidelines of premature ovarian insufficiency. According to that guidelines, puberty should be induced or progressed with estradiol starting with low dose at the age of 11 years with gradual increase. Evidence for the optimum mode of administration, oral or transdermal, is inconclusive, but we do not use combined oral contraceptive pills. And as puberty is a slow process, so hormonal replacement therapy, even we can use the term hormonal development therapy, should mimic this. And we start from 1/10 or 1/8 of the adult replacement dose and gradually increase over 2 to 4 years. And after around 2 years, we can add progesterone. But in case the pubertal failure is in older age, we can start with bigger dose, for example, 0.5 milligram per day. But till now, the starting dose and the dose escalation are not evidence-based and should be individualized. And here you see proposals how to start, from what doses, how to increase, and then we add progesterone. We use micronized progesterone or dydrogesterone. So now I would like to sum up my presentation. So cancer disease itself, as well as life-saving cancer treatment, may carry with it a risk of acute or delayed ovarian follicle loss, increasing the risk of premature ovarian insufficiency. And age at treatment is a key determinant. Prepubertal ovaries may have slightly more primordial follicles, but are still vulnerable to gonadotoxic damage. And antimullerian hormone is currently the most reliable biomarker of ovarian reserve. Fertility preservation should be offered early, ideally before gonadotoxic therapy. Ovarian tissue cryopreservation is the only established option for prepubertal girls, but carries surgical risk and risk of malignant contamination. Hormonal replacement therapy is essential for pubertal induction, menstrual cycle maintenance, and bone psychosocial health. And I think that there is a need for evidence-based guidelines tailored to prepubertal and adolescent patients. Thank you for your attention.
Thank you, Professor, for this very important insight. Since you have left us shortly, let's address the questions. We have one question from audience, and the question is, what benefit does platelet-rich plasma offer on the issue of decreased ovarian reserve or infertility after chemoradiation therapy? It comes from an anonymous attendee.
Thank you for the question, but I think that benefits are only, if there is some platel, dysfunction or low platel levels. It is not the the treatment for to increase ovarian reserve or to increase infertility.
Okay, thank you. I would like to ask you some questions before you are leaving. My questions are, what are the most common long-term reproductive challenges you've seen in childhood cancer survivors?
So I think that it is pubertal, delayed puberty. I think that problem is premature ovarian insufficiency in such girls because we have to start, as I mentioned, the treatment from the early age, and we use such hormonal treatment all her life. Okay, so I think that it is very important to start as early as it is possible and needed. As you know, that the endocrine dysfunction and hypoestrogenism is the very bad condition, not only for reproduction, but also for all health, for bones, for cardiovascular system. So I think that the biggest problem is premature ovarian insufficiency.
Okay, my second question will be, in your experience, how does the timing of treatment, prepubertal versus postpubertal, affect future fertility?
As I mentioned, the prepubertal girls have a larger primordial follicle pool. So on one hand, they are more resilient, and the menstrual recovery can be quicker. However, the same if we use high doses of chemotherapy, if you use alkylating agent, if you use bone marrow transplantation, the situation is the same in prepubertal and postpubertal girls. Postpubertal girls are more vulnerable because on one hand they have smaller ovarian reserve, but it is also they have more actively growing follicles, and those follicles are especially sensitive for cytotoxic therapy, and as a result they can experience earlier the menstruation disturbances and also the higher risk of acute premature ovarian insufficiency.
Thank you. And know about role of centers. What is the role of a consultant in the tertiary care center, like Santori's clinicals, when managing these sensitive cases?
It is not so easy because it is multidisciplinary team. So let's start from the pediatric oncologist, oncohematologist. So they must assess the risk of premature ovarian insufficiency. As I mentioned, it's sometimes very difficult at the beginning predict the treatment response. They can think that the treatment will be, very with moderate risk of premature ovarian insufficiency, but if there is no response, so they then use alkylating agents, they use the bone marrow transplantation, and in this case we will have premature ovarian insufficiency. That's why the first must be maybe oncologist who see the patient at the first. The next is very important fertility expert, because he have to see the patient and parents at the beginning before the treatment, and to discuss available options of of ovarian tissue, for example, cryopreservation. Okay, so the parents can decide to can agree with fertility expert, but sometimes for them are the most important the treatment of cancer, and they do not think what will be in the future. And the next who is also very important, I think it is obstetrician gynecologist who also monitor puberty, monitor menstrual function, markers in such girls, and also her well-being, her bone health, and start hormone replacement therapy for such girls and manage later. And also, if we speak about center, in this multidisciplinary team is also very important research, because it is important to have as much as possible experience and to register such clinical cases and to develop the protocol for fertility preservation, and especially in pediatric adolescent gynecology, it is new, because it's still now experimental, but it's really very important. That's why it is work of a big team.
Okay, we have a question from Gulia Alimbayeva. What is the balance between earlier starting HRT and risk of recurrence of cancer?
Then we speak about hormone replacement therapy in hematological cancers. There is no risk for cancer. According to literature, the hormone replacement therapy in hematologic cancer survivors are safe, and we can really treat those girls, and the risk of recurrence of cancer is minimal, maybe because of other problems, not because of hormonal replacement therapy.
Okay, and the last but not least question, as a board member of multiple societies, what is the most important message you want to send to young gynecologists who are listening us today?
So first of all, I would like that we integrate oncofertility into pediatric adolescent gynecology practice, to care. And very important is to work in multidisciplinary team together with oncologists, together with endocrinologists, reproductive specialists, and keep up to date, because it's so many news every day regarding oncotherapy, and just we have be really up to date, and especially in pediatric adolescent gynecology. And also we have to advocate and I think to educate our patients, their families, that there is opportunity, to preserve fertility, not only to think about cancer treatment, but also to later in life have the possibility to have normal family and to have children.
Thank you once again, Professor, for your time and expertise. We wish you a successful afternoon. Thank you.
Thank you. Thank you.
And now we will continue with our second speaker, Dr. Lasma Lidaka.
Hello.
Hello. Dr. Lidaka is a pediatric and adolescent and gynecologist at Clinical University Children's Hospital in Riga and the president of Latvian Association of Gynecologists and Obstetricians. Her talk is titled Not Just Small Adults, The Distinct Nature of Gynecological Cancers in the Young. Dr. Lidaka, the screen is yours.
So I hope you can see my presentation.
Yes,
and I come from Latvia. From Riga, and with a serving population of 3,500 children. That is not a big population. However, I'm and my colleagues in Children's Hospital, we are in exclusive position because all childhood cancers come to us, including gynecological cancers that I would like to discuss with you today. And indeed, children are not small adults. The distinct nature of gynecological cancer proves that. And in case of adults, the most common types of cancer we see are epithelial carcinomas. But in children, we more often see germ cell tumors, sex cord stromal tumors, and sarcomas. And that is a complete different group of diseases with different prognosis, different management, and differences in later in their life and in their life expectancy as well. And tumors in children in ovaries can arise from very different types of cells. And as I mentioned earlier, sex cord, stroma, and germ cells are the most often cause of malignant tumors in children. I would like to start with germ cell tumors, and I have prepared a small selection of cases from our center just to illustrate that this interesting group of diseases and their different causes. So germ cell tumors originate from primordial germ cells when they migrate from yolk sac to gonads. And germ cell tumors can arise everywhere along this path from the yolk sac to gonads and sometimes also to extragonadal sites. And the reason for malignant transformation is some pathologies that happen during maturation, or there is abnormal migration. So you can see the path from the yolk sac to gonads, and in all those positions, the cancer can arise, and also ectopic localizations even in central nervous system. And I would like to start with the example of first patient who was 10 months old at the presentation. She had bloody vaginal discharge and no secondary sexual characteristics were seen. Her sex hormones were within a normal range of prepubertal child. Karyotype, we received it in 5 days, was normal, and alpha fetoprotein was markedly elevated. However, I would like to stress that before the age of 1, especially, alpha fetoprotein can be elevated even in normal circumstances. So it should always be interpreted with caution. However, values above 1,000 is usually very suspicious for malignancy. And the pelvic ultrasound was performed, and here you can see I used linear probe. That is a very useful tool for the small children. And you can see a tumor 3 to 4 centimeters with marked pronounced blood supply. And with a convex probe, you can see the uterus. I will use a laser pointer, uterus and tumor. And here I've drawn with my very skillful drawing hand. The red one is uterus and walls of vagina, and the blue one is tumor located in vagina, and it was 6 to 7 centimeters in diameter. So we performed the biopsy, and the histology came back mixed germ cell tumor with predominantly yolk sac tumor component. Hence, the elevated alpha fetoprotein, that is a distinct marker for yolk sac tumors. And according to all guidelines, in this situation, surgical treatment is to be avoided as a first-line approach because we will have an enormous organ damage, and the surgery itself will be extremely dangerous. So she started with 3 cycles of cisplatin, etoposide, and ipofosfamide. And alpha-fetoprotein normalized, and follow-up ultrasound and MRI showed excellent response, only with a small residual finding, and I could not even demonstrate it to you because it was so small in the MRI that you wouldn't be able to see a thing. But it's still, as we saw, a small residual leftovers. She received a 4th cycle of pay, and now she's 6 years old and disease-free. That is really good situation. Unfortunately, she received intermediate to high risk gonadotoxic treatment, chemo treatment for her tumor. And unfortunately, ovarian tissue cryopreservation is not available in our country. I hope that it will come into reality in the next couple of years, but right now it's not available. So we will monitor her closely, and we'll discuss with her oocyte cryopreservation after menarche. On the side note, the most common vaginal cancer at this age group is rhabdomyosarcoma botroides, and this is my patient who had this huge tumor in her vagina, 10 to 7 centimeters. Unfortunately, this was a prognostically bad case, and she died later. But usually the prognosis for rhabdomyosarcomas is also more than 80% of 5-year survival. The second patient I would like to tell you about was 15 years old, and she complained of 6 months of irregular periods. Her estradiol was 113. It's not a huge number, but it's still somehow elevated. And in gynecological ultrasound, we saw a solid irregular ovarian mass, 7 to 6 centimeters. Chest CT was clear with no metastasis. And we performed the unilateral salpingo-oophorectomy with a tumor and a staging procedure. That is a classic management strategy for all types of ovarian suspected malignancies in children. And you rarely need any additional surgical treatment. So it is completely different from adult epithelial cancer, where you take out basically everything. Here we stay as conservative as possible until we get the final histological response. And her estradiol level decreased sharply right after the surgery because she had a granulosa cell tumor that is characterized by estradiol production. Hence, she had these irregular menstruations. And also pelvic fluid cytology was suspicious for tumor cells, and she received bleomycin, etoposide, and cisplatin 4 cycles. And it was 10 years ago, so the only MRI I could get to you was this in this quite bad quality. So I'm sorry about that, but this is a tumor. I see that somebody has raised a hand. Are there any technical difficulties or? No? Okay, I hope you can hear me. This patient, a couple of words about granulosa cell tumors. Juvenile type is a rare type of granulosa cell tumors, and it is characterized by high estrogen and sometimes androgen production and rapid growth. Recurrence is early, usually within the first 3 years, but with a good overall prognosis in the first stage tumors, as this patient had. And it has been, as I said, 10 years, and she is disease-free. So again, one very good ovarian cancer case. This patient was completely uninterested in fertility preservation, and she also received a low-risk gonadotoxic treatment. So her overall chances of having her own children, if she changes her mind, are quite good. Of course, we always have to keep in mind that she has only one ovary left. But considering chemotherapy, this wasn't a bad, such a toxic treatment for her. The third patient was 11 years old at the presentation. And she had already almost full pubertal development. She didn't have any menstruations though. But I wanted to show you her chest X-ray, and you can see well-developed breast tissue. And she experienced a progressive abdominal enlargement, and CT scan performed in a regional hospital showed an ovarian tumor. That is why she was referred to our center. And she had markedly elevated alpha-fetoprotein. She's a pubertal child. She would not have a normal elevation of alpha-fetoprotein. She had somehow elevated FSH levels. Estradiol, this 23 for a pubertal child, it's not very high, but it's also not very low. It's kind of, early pubertal stage estradiol. And it was already some time ago, and we started with unilateral salping oophorectomy, and the histology came back as a mixed germ cell tumor. And during that time, we did not the biopsy, but cytology with the macroscopic slide from the other ovary. Those were the recommendations we had in place at that time. And here you can see the large tumor she had. And the cytology from the other ovary came back normal. And what happened in 3 weeks' time, we received the karyotype, because at that time, you should wait for the karyotype result for 1 month. And you see her karyotype is 46XY. And so we performed the contralateral adnexectomy, because if you have a Y chromosome in the genotype, there's a high risk of malignant transformation of ovary, and you should do bilateral salping oophorectomy. Unfortunately, the other ovary also came back tumor tissue positive, and I can say you that is the last time that I performed only cytology from the other ovary. Right now, I always perform biopsy from the contralateral ovary. And she received PEI chemo. So what did she have? She has Swyer syndrome. It is 46XY complete gonadal dysgenesis. It is female phenotype with streaked gonads, but with normal uterus and normal fallopian tube and normal vagina. They almost always have primary amenorrhea and no pubertal development. And they have a high risk of gonadoblastoma, that is a benign but pre-malignant lesion, and germ cell tumors. And as I mentioned before, prophylactic gonadectomy is recommended after the diagnosis is established. And the most common type of malignant tumor in this case, in these patients, are dysgerminomas. But this patient had mixed germ cell tumor that was hormonally active. That is why she had a normal breast development, a feature you almost never see in Swyer patient cases. That is why we were so shocked about the karyotype results. Luckily for us now, karyotype comes back within a couple of days, so we are more knowledgeable at the time of surgery. She had a good height, so she needed, of course, after chemotherapy, after surgery, she needed a hormonal replacement therapy. And we started with transdermal estradiol with almost an adult dose, and progressed to the adult dose within 1 year. That is a practice that you do if the patient has already a good height. And afterwards, due to convenience, she preferred to use Perorol combined hormonal replacement therapy regimen. That is a treatment she will need to receive at least till the age of 30, as mentioned before, because of her bone health and cardiovascular health. And it can be also continued later till the normal age of menopause. Patient number 4, she was 14 years old. She had a full pubertal development. As you can see, karyotype was normal this time. And she experienced an increase in abdominal circumference within the last couple of weeks. And the tumor was detected on the ultrasound, and ascites was also observed. She had increased lactate dehydrogenase, but alpha-fetoprotein and free beta HCG was normal. Hormonal profile was normal for age, and as I mentioned before, karyotype was normal in this case. And here you can see her MRI. This is a sagittal view. Here's a spinal cord. This is a uterus. This is a urinary bladder, and this is a ascites and the lower pole of this big tumor. And here you can see abdominal view, huge tumor, a lot of fluid all around her organs. This is liver and gallbladder and intestines. So again, we perform surgery, again, according to guidelines, only unilateral salpingo-oophorectomy and staging procedure, which means blinded biopsies from peritoneum and gross omental biopsy. Guidelines say that we can choose between the gross biopsy of omentum and omentectomy. I prefer omental biopsy. I hope that I will not regret this decision later on, but I think that it's usually it's negative, apart from this case where the omentum was positive. So she had right ovarian dysgerminoma, but with a normal karyotype that can also happen, and micrometastasis in peritoneum from Douglas pouch and omentum, and malignant cells in ascitic fluid. She had oocyte cryopreservation before chemotherapy, and she received PEI 4 cycles. That is, again, as I mentioned before, intermediate high gonadotoxic treatment. And she got 6 oocytes are preserved. After chemotherapy, 6 months after that, she had a high FSH level, but it normalized spontaneously, as it usually happens. And 3 years after diagnosis, she has regular cycles. However, she has only 6 oocytes cryopreserved. She received a high-risk gonadotoxic treatment. Maybe it would be good to encourage her to repeat oocyte harvesting, or at least to understand that reproduction should not be postponed too late for her. And one other patient, I have still a bit of time. So this is her abdomen. And she saw an increase in abdominal circumference during the last month. And this is what we saw on MRI. So again, ascites all over. This is a huge tumor with exophytic overgrowth protruding outside the capsule. We did a workup. She also had changes in her CT scan in lungs, some subpleural nodules and pleural effusion. And CA125 was non-specifically elevated. This 311 for this huge size of the ovarian tumor, it's nothing. Alpha fetoprotein, free beta HCG, LDH within the normal range. And her hormonal profile was normal, and her karyotype was normal. And this is what we saw during the surgery. This is this huge tumor with overgrowth, exophytic overgrowth, containing characteristic teratoma content, fat, skin, small parts of skin, hair, follicles, and you see nodules in her omentum. And I hope you can see it clearly. All her peritoneum was covered with these small, hard, dense nodules. And those who work in adult oncology, you know this is a really bad sign if you see something like that. It was all over the place, liver, spleen, everywhere. So I had a serious talk after the surgery with the mom. And then we received the final diagnosis. Cytology from peritoneal fluid and pleural effusion was negative for malignant cells. Histology came back as a mature teratoma containing different kind of tissue, but no evidence of malignant transformation. Of course, we did not believe in that. So we sent these samples to Helsinki Clinical Children's University Hospital and to other hospitals in our country. But pathologists were strict that this is a complete non-malignant benign tumor, mature teratoma. And what was these small nodules? It was a peritoneal gliomatosis that was composed of mature glial tissue. That is a rare condition when mature glial tissue implants in the peritoneum and omentum, and it is most commonly associated with immature ovarian teratomas, but can be associated also with mature ovarian teratomas. And usually they are benign with favorable prognosis, and treatment focuses on surgical removal of the tumor, not of these nodules, because it's impossible. And it has been 3 years since the treatment. No ascites has formed, no pleural effusion. The patient is happy and healthy without any problems. And somewhere in between, the final diagnosis and surgery, she also had her oocytes cryopreserved. So as you can see, sometimes tumors in children that appear completely malignant are not malignant at all. And that is also a case in this tumor, where you can see it's a big, irregular, solid tumor that was completely benign. It was sclerotizing stromal tumor that is associated with some syndromes, for example, Gorlin syndrome, but it is completely benign, and no chemotherapy, nothing is necessary. And this is also a case in this case where our sclerotizing fibroma in a 4-year-old child. This is approximately 10 centimeter big irregular solid tumor, also completely benign. And also this tumor was benign. And those who work in the field say, of course, it's probably mucinous cystadenoma. They look like that. They grow very big. But apart from that it was not mucinous cystadenoma. It was a simple para-ovarian cyst containing 6 liters of clear fluid. So even her ovaries were not damaged. So conclusions: gynecological cancers in children and adolescents usually have a favorable prognosis. Fertility sparing management is essential whenever it's feasible, and it's almost always feasible. As I mentioned, typically unilateral salpingo oophorectomy with staging procedure is the initial treatment and usually the single surgical treatment you need. Oocyte ovarian tissue preservation is considered, and very careful communication with patients and parents is essential before you receive a final histological diagnosis. I've learned that from my experience. Learn it from me, and don't say it's cancer before you get the result. So this was what I wanted to present to you, and be happy to answer questions.
Thank you, Doctor, for highlighting these critical clinical differences. We have some questions from audience. First one is from Lasma Lidaka. Is it safe to recommend ovarian tissue cryopreservation in case of immature teratoma of the one ovary?
Yeah, that is a good question. I look at that in that way that firstly, almost very often these malignant tumors of children ovaries are unilateral. The other ovary is free of disease, and we see it right now that these people grow up and with their normal ovaries and they don't have a recurrence of the disease. The other thing is that there are underway procedures to purify this ovarian tissue, and hopefully when they will grow up, it will be possible to transplant only oocytes or to mature oocytes outside the body to be completely sure. So there is no such recommendation that we cannot offer ovarian tissue preservation for ovarian cancer patients at this age group. So yeah, that would be my answer.
Okay, the second question is regarding HRT, post-cancer management. Is the regimen differ from those used first HRT in non-cancer patients such as Turner syndrome?
Yeah, thank you for the question. There are no guidelines for this, but we generally use the same principles as for the Turner syndrome patients. Same doses, same regimens, and we see patients respond very well. And again, as Professor Bumbulienė already mentioned, cancer in childhood is not a contraindication for hormonal replacement therapy. The only cancer that we are afraid of is breast cancer and hormonal replacement therapy, but breast cancers are virtually non-existent in children. So everybody else should receive hormonal replacement therapy.
Okay, thank you. And the last question from audience for this moment is as such an 18-year-old woman with Swyer syndrome has normal small ovaries without any abnormality by ultrasound and MRI and is undergoing hormone therapy. Should bilateral ovaries be removed to prevent the development of tumor, gonadoblastoma, etc.?
Yeah, it is really advised to do that because, firstly, these are street gonads. They do not contain oocytes that could produce hormones, so there is no use of them. But the risk of gonadoblastomas and later dysgerminomas and other types of tumors, as we saw in my presentation, is high. For example, if you have complete androgen insensitivity syndrome, where you have a testicular tissue inside abdomen, then as these tissue are more mature, more, let's say, physiologically related or pathohistologically related to normal tissue, the risk of cancer is small. But in Swyer syndrome, the gonads are completely dysgenetic, so the risk of cancer is very high. So I would feel much more safer that I'd remove them and they don't have any use at all. So yeah, better safe than sorry.
Okay, one more question from Julia Alimbaeva. First, she said, thank you, Dr. Lasma. And now she has asked, what about gynecological cancer located in not gynecological places? What are rules for ovaries for childs?
So I understand the question that if you have, for example, germ cell tumor located in the brain, whether you have to be more suspicious on the ovaries. That is probably should be discussed in each case separately. I haven't come across the guidelines that says that we should be particularly worried about ovaries, but that is a good food for thought. Thank you. I will keep it in mind and think about it more.
Thank you, Doctor. And to summarize our today's webinar, I would like to ask some questions about counseling. What is your advice for patients and parents counseling strategies during the difficult initial presentation?
What I can, I've been working in Children's Hospital already 13 years, and of course read loads of literature because of all these cases I see. And now I can be calm and say that the prognosis is very good, and even the prognosis for the reproductive function is very good. It is unpleasant, it is scary, but we are quite on a good path together, and that I'm really happy about, that I work in a specialty where we have such good words that we can say.
Okay, the second question will be about balance. How do you personally manage to balance effective oncological treatment with the preservation of future fertility and long-term quality of life?
Yeah, luckily I don't have to make these decisions. These are hemato-oncologists that prescribe chemotherapy, and that is a good thing that in these cases, in one case I presented you, no, there was but we have, for example, in these germinomas in stage 1C, where there's a outgrowth of the tumor outside the ovarian capsule, we have started not giving chemotherapy, but doing an intensive surveillance for these patients, as it is allowed by most recent guidelines, and we see good results. And patients are very happy. Of course, always oocyte cryopreservation in case tumor comes back, we should take out the other ovary, so we are prepared for that. But yeah, the prognosis is still very good.
Okay. And for the end of our webinar about differences, could you summarize the key differences in tumor types and presentation between pediatric and adult gynecological patients? Yet again.
Yes. So the histological types are completely different. So our approach is different and the prognosis is different. And as to summarize the title of my presentation, the children are not small adults. When you meet them, we should always be careful, read the latest literature, and be happy with our patients that they are in good prognosis group.
Okay, thank you, Dr. Lasma, for these clear and practical answers. Thank you. And this will bring our seminar to a close. I want to thank both our speakers for their excellence and all the participants for questions and for their engagement. Have a wonderful afternoon. Thank you all and goodbye.